The goal of this presentation is not to tell you everything there is to know about pharmacological principles in the elderly. It's, they have books about it. What I've done over the last 15 years or 18 years or so, and I always brag about the fact that and it's not something to brag about, but I always brag about the fact that I haven't opened a textbook or a psychiatric journal over the last 15 to 20 years. And it's not to say that I have everything in my head. It's just to say that everything that I could have learned, I've learned it by treating thousands and thousands of patients. So, and this is what I'm going to be sharing with you a lot. It's experiences while treating patients. Because whatever is in the textbook, you can look at it, you can read it, and you will know it as much as I do. So there are some key words. We can frame this lecture in two different ways. We can speak about general principles first, and then talk about pharmacokinetics and pharmacodynamics, or we can do it the other way around. I think there are so many practical issues in the first section that I will start with it. When I do it with medical students, they like to hear drugs, receptors, and stuff like that. I usually start with pharmacodynamics. But for people who are actually going to practice geriatric psychiatry or get involved in the treatment of older people, some of those simple practical principles are the utmost importance. And they are very practical. If you ignore them, you're not really treating patients. It's a good thing to have a good in-depth knowledge of textbook stuff. For example, in geriatrics, of geriatrics or geriatric psychopharmacology, and then to be able to conduct superb interviews, arrive at complex of super simple diagnostic formulations, and then be able to formulate a treatment plan, that's good. But that makes you an extremely good physician. However, what's important when you are treating patients is the patient actually going to benefit from the treatment, for the treatment interventions that you have proposed, or is the patient capable of grasping the information? In the elderly, that's a prime question. And I have some keywords when it comes to general principles. The first word is loss, okay? I used to take a lot of time asking people to tell me one after the other, what kind of losses. I would just spend about maybe 2 or 3 minutes doing it. First I used to ask, what's the most important phenomenon that happens in the elderly? What happens is loss. I will just take a period of 2 minutes to ask you briefly, what kind of losses do you think? Can everybody tell me 2 losses that occur in the elderly population?
Social losses, losses in different types of functional ability.
Retirement.
Be more accurate, be more accurate.
In terms of the functional losses, well, changes in functional ability, whether it's around mobility, whether it's around changes in cognition.
Okay, mobility and cognition.
Social changes, like changes in terms of
somebody else.
support.
Mobility, cognition. Somebody else can tell me a few losses.
Loss of independence.
Loss of independence, yeah.
Loss of independence. Now I'm going to ask you to focus on the kinds of losses that will apply to the patient's illnesses and stuff like that. Loss of independence is quite important, okay? Loss of mobility, definitely. Cognition, extremely important. What else? There are plenty. You can go on and on if you want to, but we just take about 2 minutes.
Loss of acquaintances and
social losses.
and peers.
What's the last one?
Loss of acquaintances and peers, or social peers.
Yeah. The social losses and also in terms of the loss of social support and the fact that sort of people might move away, they might retire,
Definitely.
their children are grown up, they move out of the house, they go to
Yeah.
another state.
I have three more participants who haven't given me any responses. I'm waiting.
Hearing loss.
Excuse me?
Loss of hearing.
Hearing.
Loss. Mm-hmm.
Therefore, if you say hearing, you can extrapolate and say...
communication, isolation.
Yeah, no, but we say hearing is a sensory modality. You can include all the sensory modalities if you want, right?
Taste, sight, smell. Sure.
Exactly. All right. Anything else? Anybody else?
The loss of one's ability to provide for themselves, like their earning potential, financial security, that sort of thing.
Very good. So how do you think those things can affect or affect the elderly taking their medications? When somebody goes to the hospital, goes to the doctor, you conduct an interview. Again, you said you arrive at nice diagnostic formulations and treatment plans and stuff, but you're going to prescribe medications. Now, of course, it's true that we send the patient to the pharmacy, okay? But you want sometimes, forget about the lockdown, you want to share with the patient some ideas, you know, do the do's and the don'ts. You know, take this medication with meals, you know, take it before meals, some side effects you want to share. And the very first thing I remember Dr. Cohen almost does, he gets on his computer and he gets the biggest font he can find, and writes everything, okay? And then forget about abbreviations. There is no PO, nothing like that. It's by mouth, every day, before meals. Because if patient has loss of cognition, patient is not going to remember all those things. Then somebody, you send the patient to the pharmacy. Now the patient has to hear you, what you're giving these instructions, okay? A patient gives you the pharmacy, fine, but sometimes you tell the patient which pharmacy to go to, depending on where they live. Will they remember, based on loss of cognition, where to go, which CVS? Is it the CVS on Central Avenue? And there are two of them on Central Avenue, okay? Because my point is that even if you did everything right, if the patient is not going to be able to implement the treatment interventions in that specific case, since the course is about psychopharmacology, geriatric psychopharmacology, will the patient be compliant with the medication, okay? Will the patient be able to follow the instructions, okay, to take his or her medication? If you have two CVSs on Central Avenue, patient goes to the wrong one. Somebody mentioned mobility, okay? Sometimes the patient has to walk to the pharmacy. Can the patient do that, okay? And we can go on and on and on. Today, for the first time, I always talk about this, but I guess because I'm getting into that age group and I'm starting to take medication, so I always said I should have gone to a pharmacy and take some bottles. You know what? Now I have the bottles at home. I don't have to go to the pharmacy to pick up bottles of medication because I have different bottles of medication at home for different reasons, you know? For somebody who doesn't have any whatsoever chronic medical illness, I have quite a few bottles of medication. You know, when you're giving instructions, and you must, if there is one thing you remember, write on it, no child-proof bottles. You have to tell the farmer, you have to put that in your computer instructions, or if it's a paper prescription, whatever it is. But you have to let the pharmacist know not to give the patient bottle-proof medication. They are so different. Last year, around this time, I was maybe 2 months or 3 months away from a major cervical spine reconstruction. Everything from C2 to T1. So I couldn't use any finger whatsoever. So I had to go to intensive, how you call it, physical therapy. And all of a sudden, a lot of the stuff I used to talk about, as an instructor, all of a sudden applied to me. And I said, my goodness, this battle says to open, push, and turn. That's one thing. This one says push down, palm while turning. That requires a lot of strength. You may not think about it. I just couldn't do it. I have to call somebody ring the bell. Somebody will come. Can you open this medication for me? This one, Tylenol, says you have to line up these two things here, and after that, push it up. Well, after the surgery, they had to give you some specific pace to keep pushing and stretch, do anything, because none of your fingers could actually do anything. And here, you have to press this down, and then you pull up. And this is one of the few examples. And this one, when I'm taking, I'm going to have endoscopy tomorrow. So I'm taking one of those medications. You see, you have to press this to open it. That was one of the most difficult things I had to do, believe it or not, to use the thumb and the index together, put pressure on the thumb, and then get the medication on the other side. On the other side, you have to use 2 or 3 fingers sometimes. So it's good to know everything about neurotransmitters and neuroreceptors, what happens in the elderly, what goes up, what goes down. But if you're not every single thing you do, from now on, you have to be quite conscious, okay, quite aware of what you're sharing with the patient. Can the patient actually understand it? And can the patient follow the instructions, okay? Now, I understand that you had a lecture on polypharmacy, which is extremely good because that by itself is a whole class. But at the nursing home sometimes, I open somebody's chart and I say, this is a table of content of Harrison. You have about 17, 12, 15 syndromes, conditions listed. Everything, ranging from endocrine to, GI to cardiovascular, everything. So the patient has about 6, 7 different conditions, which means the patient might take 2 or 3 different medications for each, particularly when we're talking about hypertension, for example. They might need 3 medications to stabilize the hypertension. Now, will the patient remember what time to take them? Okay, and this is why when somebody says loss of social functions, relatives moving away, and friends, okay, children, because the patient will need somebody to remind them to take the medication. If not, you get a pill box. But even the pill box, patient has to remember it's time to open the pill box. Will the patient remember that? And so you need somebody to help the patient put the medication in the pill box, okay? And then somebody to call, it's morning, mommy, did you remember to open the pill box and take the one that says 9 a.m.? Okay, and later on, the one that says noon, but remember, you have to eat first and then you take it. Now you can say that's why they have home care, okay? The whole industry of home care, but remember, these people are called essential healthcare workers for a reason. Once they call you essential healthcare workers, besides us physicians, that means you are underpaid, okay? If you go anywhere, you hear essential healthcare workers, that means they are not the highest paid people in America. So a lot of times that may also mean they are not the highest educated either. And moreover, they cannot, are not supposed to administer medication. Sometime this week or next week, as a matter of fact, you can get it this week at the clinic. You have to get the M11Q, the form that's supposed to be filled out to make a request for home care services. Okay, it's an extremely important form for a number of reasons. One of them is at the bottom of the first page, it clearly says, can the patient self-administer? If you say no, then all of a sudden, you are opening a box of Pandora, because I will jump to the financial part of it. If this form is not properly filled out, it's going to be denied by this arbitrator, wherever he or she is. And all of a sudden, instead of the patient receiving home care services being subsidized by Medicaid, the patient now or the family has to find anywhere from the minimum wage, okay, to sometimes $25 an hour. Now you multiply that by 4, by 8, by 12, by 24, and you see how much money that is. So if you don't fill it out properly, if you let the internist fill it out, big trouble. He's in a hurry. He doesn't have time to fill 4 pages, even though that thing might be just 10 minutes. If he loses 10 minutes for every elderly patient he sees or she sees, he or she is not in business. So you're going to fill it out. So if the patient cannot self-administer, who is going to do it? Okay? Then somebody. Who is the somebody? If you put the home attendant, boom, is denied. So you have to, not to tell the whole truth. I'm not going to ask anybody to lie, but you're going to start playing with the truth somewhere. So you're going to say, well, the medication will be in a pill box. Fortunately, it's check marks. You don't have to give details. So you can say the daughter will remind the patient to take the medication. And the home attendant can do that too. So the daughter can put the medications in pill boxes, and the home attendant can open the pill box and point towards the medication and say, take this one now, okay? But now we are assuming a big role here. All of a sudden we are asking the home care person to become a nurse and administer medication, basically. So he or she can make a mistake anytime. So, and in the 4th page, this is where it's important that this page be properly filled out, because this is where they ask you for details. This is what's going to determine whether or not the patient gets 4 hours, 8 hours, 12 hours. So the more convincing and precise you are, okay, in the 4th page, then the more likely the patient will get the number of hours you're asking for. They are more likely to deny anything you ask than to offer it. So you always make an argument for more so you can have less. And you have to find the arguments that will convince whoever that is, okay, in whatever office that's going to approve or disapprove the hours to go on your side. So if you want 8 hours, if you think 8 hours will suffice, you ask for 12, because they will never give you 12. Now, 24 hours is not 24 hours. 24 hours is 12 hours. They only pay 12 hours. They assume that the other 12 hours you're going to sleep. Now, you tell me, if you have somebody who is demented, if they are going to sleep 12 hours at night, if they are going to sleep 8 hours and stay quiet during 8 hours. So actually, you are always working 24 hours. So if you want 24 hours, you have to make an argument for 24 hours. Therefore, you have to come up with stuff like patient is incontinent of urine, incontinent of feces, if the patient is actually, okay? But more often than not, patient will be incontinent of urine. And if you don't change your diaper every few hours, patient is going to develop bed sores. Now, all of a sudden, we're talking about infections. Now we're talking about hospitalizations. So it's going to cost Medicaid way more money if the patient is in the hospital than if the patient is at home being taken care of by caregivers, okay, the strangers 5 days and the family 2 days, or strangers for 6, 7, 8 hours until the daughter comes home. So once you make this argument, they are more likely to approve 2 people for 12 hours. In that case, each person is paid for 12 hours. But if it's for 1 person for 24 hours, this person is only reimbursed partially, not the whole 24 hours. So these are details that appear unimportant, particularly in a class about psychopharmacology. But remember, you're making an argument about care in general, but primarily at the bottom of the first page about medication. If the patient doesn't take the medication, therefore it doesn't matter how good you are at your diagnosis, you are able to diagnose Lewy body dementia versus vascular dementia versus frontotemporal dementia. You did all of this, and then what happens? Nothing. Treatment is not being implemented. The other thing, in polypharmacy, you see, once you start getting plastic bag like this, then you know you're really getting to be an elderly person, okay? Because you cannot put them on the counter anymore. on the night table, it will take too long to look for it. I have medication from last year, okay? Because once in a while, you have to take something for pain. You still have neuropathy, okay? And in the meantime, you went to see the urologist. And in between, like tomorrow, you're going to see the GI doctor. So you have all kinds of medication that you're taking. And remember, I have no chronic medical condition. You just can imagine if I have high blood pressure, diabetes, COPD, any one of them. So you tell the patient to come before the appointment, whoever schedules the appointment. Extremely important that the patient come with all his or her medication, put all of them in a plastic bag, including Tylenol. You must say that, okay? And the reason why you say including Tylenol is because Tylenol, a lot of times, is Tylenol PM. And what is Tylenol PM? Tylenol PM is Tylenol plus an anticholinergic drug. Scopolamine, usually diphenhydramine, Benadryl. And we're talking about anticholinergic side effects. We're talking about peripheral and central anticholinergic side effects. We'll talk about that in a minute. So that's the reason why you say that. When the patient goes to the pharmacy to get something to sleep, the patient doesn't understand its medication, okay? And between us, okay, there is a lot of hypocrisy in the whole thing because diphenhydramine 25 milligram is over the counter, 50 milligram, you need a prescription. So what's the difference? Patient buys one, it doesn't work, patient takes two. All of a sudden, the doctor is not prescribing diphenhydramine, but the patient is taking a prescribed medication, patient is taking 2 tablets of 25. And what I might as well go over that now, just in case we don't have time, because it's never enough for 1 hour. Anticholinergic drugs, you go from the head down. You have anything from blood vision, from blood vision to dry mouth, which can be unbelievably unbearable. Okay, and then you go down to dry throat. You go down to tachycardia. You go to decreased intestinal peristaltism. You go to urinary constipation, urinary retention. You know, all of that. Then for somebody whose cognitive functions may be impaired, you may also have features that make the patient very confused, interfere with memory. So you complicate conditions that are already present, and then you make them worse. So I remember when I was a practicing physician in charge of inpatients. So this is what I did for 16 years, primarily 4 years as a resident and 12 years as a unit chief. I always tell my the Downstate resident, Kingsborough residents, we used to have Brookdale, Maimonides, everybody will converge in one place for geriatric psychiatry. We were the focus of geriatric psychiatry, so every teaching hospital would send the residents. Then we had staff. I always conduct rounds with nurses, social workers, and I always became very dramatic when I was talking about anticholinergic. I always say to my residents and staff, if I ever find out you are prescribing a medication that's very anticholinergic to my patients and you don't know anything about it, or you didn't take the necessary precautions, I will have you beheaded. And I use the most dramatic thing I could think about. I will have you decapitated because you cannot do that to an elderly person. You see what I mean? I try to scare I was going to say the SH, but I would try to scare the hell out of them because you have no idea. I remember personally going to an interview with the medical director at Kingsborough Psychiatric Center, and all the chief of service were there. And at one point I tried to speak and no word would come out. This is how dry my mouth was because I took 1 tablet of, I forgot what medication that was very anticholinergic before I left home. And then my mouth was so dry, I could not speak at all. And this is the least concerning. of all the side effects we're talking about. When we talk about severe constipation for 5, 6, 7 days, patient goes to extreme means to put paper clips in the anus to try to remove feces because the nurses did not give them the medication on time and they cannot support it. Urinary retention is the worst thing you can ever have. I know it from experience back in 1997 when I had my first neck surgery. And I begged like a kid to get me out of a drug trial they were doing with some pain medication. When your bladder is full for hours, 4 hours, 5 hours, 6 hours, you cannot empty it. You will go to the second floor without using a ladder, okay? So they had to get me to give me a catheter. Then you cannot be catheterized too long. They remove it. Boom, retention again. I scream again. They remove it. Then finally, I had to get out of drug trial one day before, one day earlier. So we're not joking about stuff here. We're talking about stuff that are extremely important that will determine compliance. And at home, what do you think the patient does? The patient doesn't have a nurse to call, catheter in, catheter out. You see what I mean? The patient just stops taking the medication. And that's why the patient comes to you a month later. Patient has taken the medication 2 or 3 times. It was too much. You will wait when they see the doctor to tell the doctor, this, I'm very sorry, I couldn't continue to take it, or I couldn't open the bottle, okay, or there was nobody to give it to me, all the things I just mentioned to you. So these principles, quite not scientific, are the most important issues you have to remember when prescribing medications to elderly patients. And then you have the general principle that you may have heard many a time, is to start low and go slow. We from the old era are extremely familiar with this principle. We had to implement that on a regular basis for a number of reasons. We didn't have the atypical antipsychotic when I started psychiatry in 1980, okay? Actually, a little bit earlier in Haiti, in 1977, and I came here starting 1980, residency, fellowship 1984. So I became unit chief after that. So all we had was the conventional antipsychotics and the tricyclic antidepressants, not heterocyclic antidepressants. So which means all the medications we avoid nowadays because of severe adverse effects, that's the only ones we had when we were practicing medicine in the 80s, psychiatry in the 80s and 90s. So we had tiohidazine, melarine, chloromazine, thorazine, haloperidol, haldol, tiohexine, navin. Wherever you turn, either you were dealing with sedation, okay, because of the effects on histamine receptors, either you were dealing with postural hypotension because of the effects on presynaptic alpha-2 receptors, or you were dealing with severe anticholinergic side effects. It doesn't matter what, all cardiac side effects with the heterocyclics. Therefore, you had to become an artist. Prescribing medication was more to the elderly, was more an art than a science. And you will give somebody 50 milligrams of melarine, you go to 75, and you had terrible anticholinergic side effects. Now, what do? Do you change immediately to another drug? No, that's not what we used to do, okay? We will discontinue the medication for 3 or 4 days, and then we'll start with 12.5 milligrams this time. And then we'll go from 12.5 to 25, and instead of increasing every other day or every third day, we'll let the patient stay on 4 or 5 days. Of course, you have to remember at the time, we didn't have managed care and stuff like that. That will tell you when to discharge a patient, even if I was practicing at Maimonides, a private hospital. But also in a state hospital like Kingsborough, there was no such thing. Time was not a major factor. But even if it was, like at Maimonides, that was the only way to prescribe medications appropriately. And I will be telling you today, that's the best way to still do it. Even though we have a bunch of forces that push us to prescribe otherwise, but we're not doing the right thing by pushing medication too forcefully. And the thing I will ask you to do to finish with the general principles, I never, ever give medication to an elderly patient and say that I give you an appointment and you come to see me in 2 weeks or 4 weeks. Never. I always ask the patient, himself or herself, or a caregiver, to call me the following day, maximum 2 days, and tell me how the medication works. Because I have no idea. Doesn't matter how many thousands of patients I've treated over the years. I have no idea how to anticipate exactly how this patient is going to respond to this particular dose of medication. Somebody will give 12.5 milligram of quetiapine Seroquel. They become extremely drowsy to the point that the blood pressure may go down. Somebody else will go up to 100 milligram, nothing happens. I would take Benadryl, it will literally knock me down. When I was on call, I wanted to sleep for some hours. The next day, I was worth nothing. In the meantime, my late wife will take it and sleep for hours and hours. Okay? She will take benzodiazepine. It doesn't do anything. It didn't do anything to her. Okay? I take benzodiazepine. It will knock me out. So you don't know this particular patient, how she's going to react. That's the reason why you ask the patient to call you the next day, to ask the caregiver to call you in 2 days, in 3 days, and then over the phone, you increase or decrease the medication. This is why instead of giving 25 milligram, I would always prescribe 12.5 milligram or so and say take 2. This is just in case I want to decrease the dose. I can always go from 25 to 12.5, okay? Instead of going, because if it's 25, I'm going to start saying break in half or go back to the pharmacy to get 12.5. You understand? So these are simple, principles, but again, that will maximize compliance in the elderly patient when it comes to medication. Now, we'll probably spend more time in that than anything else because they are the most important, and you can take it from me, okay? Now, when it comes to pharmacokinetics is, to put it simply, what happens to the drug, what the drug does, what the body does to the drug, and pharmacodynamics, what the drug does to the body. Okay, very simply put. Okay, in the pharmacokinetics we have absorption, ADME, absorption, distribution, metabolism, and elimination. Okay, so I will not go into everything that has to be said. Let's just say when it comes to absorption, there's nothing significant that happens to older people, except that if they take other drugs like anticholinergic drugs that decrease peristaltism, you may have a delay in absorption. Otherwise, there's nothing much that happens when it comes to absorption in the elderly. If you're talking about alcohol is absorbed in women, for example, in the stomach. Okay, so you have to be very careful when it comes to using alcohol and taking medication and stuff like that. And basically, some drugs are metabolized in the small intestine, like chlorpromazine, like a conventional antipsychotic, or like, for example, some benzodiazepine, okay? Very long-acting benzodiazepine that we don't use as much. But besides that, nothing much to talk about. Now, the next one is distribution. That's important. Distribution where? Where are drugs? Let me give you a chance to say something here. Where are drugs distributed in the body? Anybody, elderly or not? Where are the drugs distributed? I see Amile, I see Billy Yang, I see Sarah Leventer, but I don't see their faces. And Tonya, I don't see her face either, but I'm assuming they are here.
I was eating, sir.
So where are drugs distributed when a drug is administered? We don't have a bunch of solvent for the drug to be dissolved in. It's either in water.
To the brain, to the extracellular fluid, to the intracellular fluid.
No, not so much organs. Not so much organs. I'm talking about the solvent. Where are they distributed?
The blood.
The blood, okay. When you say blood, you know you're talking about a bunch of things. So, but fine, blood. And then what? Where else?
Fat.
Fat. Okay. And then more or less that's it. And then you said some tissues, you know, interstitial tissues or tissues in general. And once you remember that, so I'm asking you to do something that I've always done. I may not do it as much anymore, but when I had fellows to train and residents to train, particularly when they were coming from all kinds of hospitals, we had to do things right and do it right all the time. So we had to teach and teach and teach and teach and teach, because whatever knowledge acquired during the first during that year was basically what you're going to be using all your life. So it behooves you to know, is a drug lipid soluble? Is a drug water soluble? Okay, because that will determine everything else. Now, all the psychotropic medications that we prescribe, do you know how many of them, if it's most of them, if it's all of them, if it's none of them, are dissolved in fat or water? You can take a chance. It's 50-50. Either wrong or right. Not that bad as if you go into bed. Have I lost you guys, or?
I'll
Fat.
go with
I'm going to say
fat.
fat.
You say fat. Okay. All psychotropic drugs are fat soluble, except only one: lithium salts. All psychotropic drugs are lipid soluble. So all of a sudden, it's important to know what happens to fat, what happens to water in the elderly. What happens to fat in the elderly? Increase or decrease?
Increased.
Yes. Fat is definitely in women. Women have more fat than men up to a certain age. By the time they get in the late 30s and stuff like that, men pick up. You know, you always see the those beer bellies and stuff like that. You know, so you know, fat increases in the elderly, and then we all get a little bit bigger as we get older for 10,000 different reasons. So if we say all psychotropic drugs are fat soluble, so it's extremely important to know what happens to the drug after absorption. Okay, and we call it the VD, capital V, lowercase d, the volume of distribution. So the more lipid soluble the drug is, the more widely the drug will be distributed. The other important thing important when it comes to distribution, somebody mentioned brain earlier in terms of location. Okay, I think it's Tobias who said that, if I'm not mistaken, or Louis, one of them, is the brain. Most of the psychotropic drugs we give, if not all of them, we give them so that they can act in the brain. Okay, the receptors we're targeting are not peripheral receptors. Okay, we're always targeting centrally located receptors. And in order to do that, the drug has to cross the blood-brain barrier. And what is the blood-brain barrier? It's a lipoidal barrier, primarily fatty. Therefore, the more lipid soluble the drug is, by the way, talking about absorption, the more quickly the drug will be absorbed from the GI tract into the general circulation, and from the general circulation to cross the blood-brain barrier to act on the receptor. An example is when we give Cinemet for Parkinson's disease. Okay, we give L-Dopa and carbidopa. The L-Dopa is the one that we want to cross the blood-brain barrier. So that's going to be transformed into dopamine. Okay, But if we give it just like that, it's going to be destroyed into the periphery. So we give the combination of L-DOPA and carbidopa, okay? Because it's carbidopa is a peripheral decarboxylase inhibitor, meaning that the carbidopa inhibits the decarboxylation of L-DOPA into dopamine in the periphery. So L-DOPA is not decarboxylated into dopamine into the periphery. It has enough time to cross the blood-brain barrier. That's a typical example, okay, of where how lipid solubility is quite important when we prescribe medication. All right, and so lithium is lipid soluble. Therefore, we don't have to worry about fat tissue. Now, besides fat, we say this in the blood. When we say blood, are we talking about entire blood or plasma? If you are ordering levels of lithium, for example, be precise, be accurate. Don't say blood level of lithium, because lithium is not, what we're looking for is not lithium bound to white blood cells or red blood cells or platelets or anything like that. We're looking, now we're looking for the lithium in the serum, where you have the proteins, albumin, globulin, alpha glycoprotein. We're talking about plasma, okay? So always say plasma, lithium plasma levels. That's what you are ordering. So any drug, when it comes to distribution, after absorption, is taken by the general circulation into the liver. I will skip that part because it's already metabolism, okay? And then the drug either crosses the blood-brain barrier to go into the brain, or the drug is metabolized while it passes through the liver, enough to be inactive, to be excreted, or it undergoes multiple passages through the liver, okay, while doing what it's supposed to do at the receptor level, until it becomes hydrosoluble and is excreted by the kidneys. In other words, any drug that's lipid soluble, until it's metabolized to become hydrosoluble, cannot be excreted by the kidneys. Except the lithium is not metabolized, okay? And the lithium is not distributed anywhere, okay, except in the plasma. So lithium, what's important is absorption and excretion. So what you need to know about lithium is which drugs interfere with the absorption of lithium and which drug interfere with the excretion of lithium. And I will ask that right now, okay, for time issues, because remember, I want to give you the practical stuff, not everything that's written in the textbook. What drugs do you know, because you must know, interfere with the excretion of lithium?
Diuretics?
Yes.
NSAIDs?
Yeah. Yes. So you got it, man. So diuretics, because they will do what? Always think about sodium. Whatever the drug does to sodium, it does the opposite to lithium. Diuretics do what to sodium?
Increase the excretion of sodium.
Very good. Therefore,
Increase the excretion of lithium.
They cause lithium retention.
Oh, okay, understood.
Okay, it's if you remember the periodic table of Mendeleev, you have hydrogen, lithium, sodium, potassium, rubidium, cesium, strontium in the first 1A column. So lithium and sodium are not too different from each other. One is atomic number 3 to one is atomic number 11 to 81. So the body has a tendency to confuse one over the other. What do the NSAIDs do? Remember, we're talking about elderly. We're talking about Motrin, we're talking about naproxen, we're talking about the other one, well, these two in particular. So what do we give them a lot for pain in the elderly? So what do they do to lithium?
Decrease excretion?
actually they cause lithium retention. They interfere with the excretion of lithium. Okay? And so you have to be very careful. In pregnancy, even though it's not the elderly, but it's good to remember that, you have sodium retention, right? Causing eclampsia, preeclampsia, and all this kind of thing, people with hypertension, you know, in pregnancy. So you have sodium retention and you have increased lithium excretion. So your manic patient that was controlled, all of a sudden is not controlled anymore. And remember, lithium toxicity is not a joke, okay? I had my few shares of lithium toxicity. When I say my few shares, I had my few shares, okay? And I will never forget them. I remember the names of every single one of these patients, which hospital they went to, and what happens to every single one of them. So you don't want to have lithium toxicity. And the important part is the polypharmacy that classes that you had. Remember, maybe you're not the one that's going to prescribe the NSAID. It's a primary physician or one of the other specialists. So you always have to update, ask the patient, are you taking any new medications? Because you are prescribing the lithium for 4 years. All of a sudden, this doctor last month started giving the patient Motrin. All of a sudden, you're going to have lithium toxicity. Who is going to be responsible? You are the primary physician. Both, if something happens. And stuff does happen. A lot of stuff. Okay? So lithium excretion is potentially fatal. And the patient always go to a general hospital. You're not there. And these guys do not know, do not appreciate the severity of lithium toxicity. Therefore, they don't treat it very well. I used to go to the hospital, Kings County or Kingsbrook, to personally monitor in the morning and at night what happens to the patient that I referred to for lithium toxicity. Okay, because they are not going to do it well. They are not going to take lithium more than once a day. What would be the purpose of checking lithium once a day? Let's say you give the patient lithium this morning, 600 milligrams, and then you find out that the patient had taken the lithium before getting the lithium level. Now, are you going to wait until tomorrow morning to draw the lithium again and to find out exactly how was the lithium levels? No, you don't have to, okay? So what you do, for each 300 milligram of lithium that you gave, you withdraw 0.3 milliequivalent per liter. In other words, if you find that at 10 o'clock that the lithium level was drawn this morning, remember the serum lithium level, not the plasma, not the blood. If you find that out and you suspect you have some side effects, and remember the side effects you have with lithium are the same symptoms you have with mild lithium toxicity. There's no difference. So you don't know if you're having side effects, mild tremors, nausea, vomiting, diarrhea, if you're having mild lithium toxicity, or if you're having just some adverse effects. The only way to know is to measure the serum lithium level. But it's 10, 11 o'clock, the patient got the medication at 8 o'clock. You know it's going to be high. But you don't wait tomorrow morning. That 24-hour period may be very consequential. So you take the lithium level at 11 o'clock anyway. And then if it's 1.3, that will be toxic levels. But because the patient took the medication this morning, you don't know. But yes, you may know. For every 300 milligram the patient took, you withdraw 0.3 milligrams. So if the patient took 600 milligrams, out of this 1.3, you remove 0.6. So the actual lithium level, the trough levels, had the patient not taken the medication this morning, would have been around, 0.7. And then you can deduct whatever information you want. Okay? And while talking about lithium solubility, I took some time to talk about lithium because that's the only hydrosoluble drug that we have. Okay? The other thing to know about lithium, okay, again, I'm not all over the place. That's the only hydrosoluble drug we have. And if I have more white beard and hair now than I should have had, is because of three conditions in psychiatry. It's because of suicide. I had 2 of them. It's because of lithium toxicity, maybe 12, 15 of them, and neuroleptic malignant syndrome. I think I had about 8, 9 of them. Each one of them is fatal. Suicide, of course, you're the same. If you suicide attempt, maybe not, but completed suicide is. So you have to know these things because a lot of them are not written in textbooks. Everything I'm telling you is from experience. Okay? So after a while, you know everything you need to know. Unfortunately, you learn it the wrong way, or maybe the right way. So when we're talking about lithium, for example, it's moderate lithium toxicity presents itself primarily with neurological symptoms. Okay, gross tremors, not fine tremors anymore. And you have all kind of problem with muscles and nerves. The reason why I'm saying that is because most elderly patients do not have mild lithium toxicity. They go from normal serum levels to moderate lithium toxicity. Therefore, what you have is primarily neurological symptoms. And if the patient is on antipsychotic, all of a sudden you're thinking about the antipsychotic causing some of the problem you have. Okay? That's not true. It's the lithium. Most elderly patients skip the mild lithium toxicity phase to go straight to the moderate toxicity phase. So it's extremely important that one remember that. Now, distribution again, most drugs are fat soluble. They go to the brain. And what happens? They act on the receptors, and you have what we call onset of action. Now, when we talk about half-life, sometimes we confuse half-life, which has to do with excretion. We confuse that with onset of action. So let me ask this question, and that will sear the information into your brain. If you're going to give somebody a medication tonight, let's say I'm going to have endoscopy tomorrow, and if I have difficulty sleeping, 7 o'clock I have to be in Brooklyn, at an NYU clinic, and somebody wants to give me a benzodiazepine or a sleeping medication so I can fall asleep easily, at the same time be alert enough to drive to the thing tomorrow, even though I will not be driving back. Which of all the benzodiazepines that you know, which will you give? You don't want me to stay up until 3 o'clock in the morning after taking the medication. You want me to fall asleep about half an hour. But you want me to be alert enough, if I'm going for an interview, I can go and sit for the interview without being drowsy. Which medication will you give? Which benzodiazepine?
Lorazepam?
Lorazepam. Ativan? Okay. Anybody else? Will you give, okay, go ahead.
Zolpidem.
Zolpidem. Okay, Ambien. Anybody else? Will you give Valium, diazepam?
What about midazolam?
Yes.
Midazolam, Versed. Well, talking about endoscopy, that's what they used to give until about 12 years ago, 14 years ago. Now they give propofol. I call it the Michael Jackson's drug. Okay? Midazolam shares unique properties that no other benzodiazepine shares. It's the quickest acting. It's also the shortest half-life. That's why we used to use it so that's not too bad a bet, midazolam. But remember, after 2-3 hours, you may not find it in the blood much at all. So you may wake up if you have difficulty sleeping, let's say it's anxiety or something like that. Will you give diazepam? I didn't hear yes, I didn't hear no. Diazepam Valium, it has a half-life of 24 hours, just to be helpful.
Might still be groggy in the morning with that one.
Okay, this is what happens. What's important right now? Two things are important. Two things are important in pharmacokinetics. Single dose pharmacokinetics, multiple dose pharmacokinetics. And then different conclusions. What you just said, what happens in the morning is very important, but if it's single dose pharmacokinetics, is it important? The more lipid soluble the drug is, the quicker is the onset of action. Meaning that because remember, the drugs are absorbed in the GI tract, and the more lipid soluble the drug is, the more quickly it's absorbed through the GI tract, and also the quicker it goes through the blood-brain barrier, which comprises lipoidal tissue. So the lipid solubility facilitates two things: absorption in the GI tract and traversing the blood-brain barrier. Quick onset of action. So will diazepam be a good drug to give just based on these two conditions? If you want to take a drug, fall asleep early. Now, waking up tomorrow morning, will you be drowsy? Probably not. Why? Based on what I just said. Any answer? Based on what I just said, will the drug make you drowsy? I think, Shirley, Ms. Duard, you're the one who said about drowsiness in the morning. Was it you?
No, it was me.
I was asking about alternatives to medications that would supplement some of the drug effects.
Yeah, but the morning after, you're concerned about that because you're going to take an interview. You want to take a benzodiazepine that will act quickly, onset of action, but that will keep you alert tomorrow morning. Diazepam, believe it or not, is one of the ideal medications for that, for two reasons. One is very lipid soluble. It crosses the GI membrane very quickly and crosses the blood-brain barrier very quickly. Therefore, in 15 minutes, you may be asleep. If you're not used to taking these medications a lot every night or something like that. But it goes, because of its lipid solubility, it is distributed primarily in fat tissue. So it goes to fat immediately after that. So if you measure diazepam Valium in somebody's blood 2, 3, 4 hours after taking the medication, you may be very surprised to find very little diazepam or none at all. That's how great the affinity of diazepam is to fat. I remember having a big argument with a doctor at the Memorial Hospital, when Memorial was a standalone hospital. And I had a company that used to cover the emergency room, and because they didn't want to hire a psychiatrist. So the doctor wanted to discharge somebody who had taken an overdose of lorazepam or some benzodiazepines after 4 hours. And he and I got into a big argument. I said, no, it's too early. You have to keep this patient for another 4, 5, 6, 7 hours. He said, we don't have beds in the emergency room for that. I said, but we have to, because you may have a bigger emergency if you send this patient home. And I had to explain to him that I think it was a medication, though some heterocyclic antidepressant. I said, most of the medication that the patient took will not be in the blood at this particular moment, in the cardiac tissue. Therefore, you have to wait until they are released back into the circulation, which will take a few hours to appreciate. Or you have to do an EKG to look at the PR interval, because heterocyclics have serious cardiac effects. Now you may say, well, we don't prescribe that anymore. Yes, you do to augment the effect of antidepressant. And yes, you do because primary physicians give it, okay, at very low doses to control certain conditions, like neuropathy, for example. They give Elavil at very low doses. So, yes, the medication will act faster, And yes, the medication may not be available in the blood 6-7 hours later, but tomorrow in the afternoon, patient may be very drowsy. That's when the drug is going to leave the fat reservoir site to go back into the blood plasma compartment. So you have distribution in the blood plasma compartment and redistribution into fat. So lipid solubility is extremely, extremely important, okay? When it comes to metabolism, primarily it's the liver. Drugs are also metabolized in the kidney, drugs are metabolized in the brain, but drugs are metabolized primarily into the liver. Some drugs are metabolized through first passage through the liver, and they become lipid hydrosoluble, they are excreted to the kidney. Some drugs may need to pass through the liver 2, 3, 4 times because each time they give you a different metabolite.